So good morning, everyone. Hello. My name is Martino Cellerini. I'm an Italian and originally from Florence. And I am an old acquaintance of the OUH since I spent 6 years from 2008 until 2014 working at the OUH. Then I had a 6-year stint in Italy, and then and now I'm back to Oxford as a consultant, INR consultant, since April last year. Today I'm going to talk about intracranial venous stenting. This is really probably a very hot topic, and I'm stating no conflict of interest, obviously, regarding this topic. I obviously I don't claim to be an international expert on this topic, but I have been doing this work for at least 23 years, and I started treating idiopathic intracranial idiopathic hypertension in Italy back in 2015. That was my first case. This is my personal caseload. There are not many cases. There are definitely many people more experienced than me on this topic. Also here in the UK, especially in Cambridge, where Professor Higgins started to study this peculiar disease, and also in Southampton, where my colleague Jason McDonald has a pretty good experience on this topic. But anyway, I did 22 cases between 2015 and December 2021, and I think that's enough cases to grasp the gist of the procedure and the important features of the disease. So you see that usually I've done, of these 22 cases, 3 cases did not proceed to stent because of insufficient venous gradient, and we'll talk about that. And I did the procedure in 19 cases. Usually I split the procedure in 2 separate sessions, one diagnostic and a local anesthetic. And if the venous gradient measurement is positive and there is a good indication for treatment, I then proceed for stenting and the GA, obviously with premedication with dual antiplatelets therapy. 4 cases had only pulsatile, synchronous pulsatile tinnitus and headaches, no papilledema, but most of the cases had progressive vision impairment. And I managed to follow almost all of them with at least 1 year CTA, and the results, the outcome is was pretty satisfactory. Only 4 patients had a temporary improvement with a partial improvement after 1 year. So why do we need to talk about intracranial venous stenting now? Because maybe the timing is mature to start thinking about introducing these kind of procedures also in our trust. There's not a big amount of evidence and about the usefulness of endovascular treatment in idiopathic intracranial hypertension, but I think there is enough publication and to suggest that we can build up a pathway or a protocol, a diagnostic and clinical and therapeutical pathways to give an option, a treatment option to this patient. It's quite a fairly large. There's quite a fairly large population so patients are pretty numerous, and most of the referrals are from, at least in this year that I've been working here, is this year and a half that I've been working here, I've got several referrals from District General Hospital and even some from the general practitioner, but I couldn't basically offer them any definite treatment proposal because this is a fairly new procedure, and I think this is the aim of this talk, basically, to see if there is enough people interested in building up protocols and diagnostic and therapeutic pathways so that we can offer this patient therapeutical alternative option to surgery. Obviously, idiopathic intracranial idiopathic hypertension is the tip of the iceberg. So we need to have a very careful patient selection. And this is probably the most important thing. The pathophysiology, the most accepted pathophysiology of this disease is due to venous outflow impairment due to a stenosis. At the beginning, we thought that the stenosis, it was important to differentiate the primary from the secondary stenosis, but nowadays, basically, the most important thing is to diagnose a stenosis, mono or bilateral, stenosis of the transverse sinus. So the stenosis usually causes venous outflow obstruction. This is cause venous hypertension and impaired CSF absorption. And so it's a cycle, and which should aim to break down this cycle, either by, and we'll see what are the treatment options later on. As I said, the important thing is patient selection. And the main stain is to have a very good face-to-face consultation, because these patients are a peculiar set of patients. They have, most of them have psychological problems, and so we need to be absolutely certain of their reliability and compliance, because if they are supposed to go on for an endovascular treatment, they need to be compliant with dual antiplatelets therapy. So we are looking for headache, papilledema, progressive vision loss, and obviously these patients are young, usually female, and with a BMI over 30 kilograms per square meter. Their quality of life may be rubbish because mainly of synchronous pulsatile tinnitus or headaches. Sometimes there is a CSF leak, and I mean, how is it possible? I mean, this is a consequence of the hypertension. So CSF may leak through the ethmoidal plate or through the tegment tympani and the mastoids. A very important thing to do during the outpatient consultation is the compression of the internal jugular vein and the common carotid artery to especially in patients that have a pulsatile tinnitus, because this is a very important test, and if the tinnitus disappear or decrease significantly with a compression of the internal jugular vein, means that the stenosis of the transverse sinus is most likely the cause of the tinnitus, and the same applies to the carotid compression. If there is a tinnitus, a pulsatile tinnitus that disappears with carotid compression, maybe that the cause is in the artery and not in the vein. Very important is to set up a diagnostic protocol. I received, as an INR and diagnostic neuroradiologist, we have lots of requests for pulsatile tinnitus, and the most common diagnostic exam is MRI of the posterior fossa, or with an MRA, a simple 3D time of flight angiogram, MRA angiogram. But this is really not enough. This is enough mainly to rule out dural arteriovenous fistulas, but not to rule out adequately other cause of pulsatile tinnitus, like venous or stenosis, or arterial aberrant arteries, or things like that. And so the most useful tool to detect a venous stenosis is the volume 3D imaging after contrast. And sometimes we need to do also high resolution CT or CTA of the temporal bones, just to rule out some descents of the vessels into the middle ear cleft, or even the mastoid, or peculiarly or even enlarged hemispheric vein. So this may even be the cause of pulsatile tinnitus. Recently, there is also a trial that's been started in Birmingham. So the goal of this talk is also to set up these protocols, this diagnosis and therapeutic growth, so that we can probably offer treatment in the framework of this trial. That's only been recently proposed, and it's only been recently started. It's last year basically, and it's still ongoing, obviously. So that would be nice to offer this treatment within this research framework. So what are the tools we have to diagnose intracranial hypertension? Obviously, we talked about CT and MRI. Obviously, very important is the eye exams to see whether there is a swelling of the papilla, especially in patients with there is papilledema or as a cause of progressive vision loss. Still important is the spinal tap to evaluate the pressure, and sometimes we can even take out CSF, and if the symptoms improve, this is a good test that there is an intracranial hypertension, and obviously a visual field test. As you see here, on MRI, the main features are enlargement of the optic nerve sheath with flattening or even protrusion of the papilla in case of papilledema. Usually there is an empty sella, a large empty sella, and obviously a venous MRA, a venous MRV shows that there is some problem with the transverse and sigmoid sinuses. A very important thing to understand is the most reliable, that DSA is not the best tool to diagnose a venous stenosis, okay? Because obviously DSA is a projection, imaging in DSA are projection views, projection imaging, and so the most reliable exams to diagnose a stenosis of the transverse sinus is a post-contrast TIM1 volume acquisition on MR. Okay, so I mean, everyone knows the definition of intracranial, idiopathic intracranial hypertension. The main symptoms obviously include vision loss, headaches, pulsatile tinnitus, and CSF leak. So this is the things that we need to look for. A few points. Patients sometimes, these are questions that patients often ask at consultation how serious it is, and it may be very serious, especially there's a few cases of fulminant hypertension, intracranial idiopathic hypertension, and if you don't act promptly, there is a high likelihood to have a permanent vision deficit of vision loss. Usually these cases are not really good for endovascular treatment because we need to have on board dual antiplatelet therapy to do the stenting. So in these cases, probably the best thing to do is to offer them a surgical option, that is an endoventricular drainage, and then deal with the stenosis of the sinuses once the acute stage is over. Can we recover from idiopathic intracranial hypertension? This is another very common question, and it is, I mean, this is it's debatable because we don't have long-term outcome results. And but definitely the venous stenting is a very effective treatment to sort out, especially in patients, to sort out the symptoms, especially patient with progressive vision loss. What are the most common complications? I mean, obviously, is vision loss. So this is our main target, to stop it, to stop the papilledema, to relieve the pressure, and as you see, as much as 50% of the patient may be at risk of severe permanent vision loss. Headaches also are a source of disability and decreases quality of life, but this is more difficult to sort out. From a treatment point of view, we have several options: optic nerve sheath fenestration, serial CSF lettings, and shunting. These options have pros and cons, but definitely venous stenting is a pretty straightforward procedure. And we have now several case series, and we'll see some of them. And there's been recently published meta-analysis. The problem is that we don't have data on long-term efficacy of stenting, and there might be some doubt that this technique is effective in a long-term outcome. There is also obviously the option of bariatric surgery and a surgical weight loss strategy. I mean, medical treatment usually, in my experience with Diamox, is not very effective, and it implies quite a lot of side effect. It's not an easy treatment to be accepted by the patient, and usually after 3, 4, 5, 6 months of therapy, they are desperate and come to you for help. So everything started in 1994 with this publication, and this is obviously it's a case report. Most of our activity comes out from case report, and they inflated a balloon. It was a patient with a synchronous pulsatile tinnitus and a transverse sinus stenosis. They inflated the balloon, and the tinnitus immediately disappeared. And this is a proof that the compression test when you are at consultation is really, really important to understand whether the cause of the tinnitus is a venous stenosis. This was followed by several publications some years later. This is from Professor Higgins in Cambridge. He studied quite a lot of venous diseases, and it had positive results. There are other publications, a small retrospective series of 52 patients, and more recently, 2019, there's been published a meta-analysis with the complication, and in a total of 474 patients. And you see that the outcome is pretty good with the intracranial stenting, venous stenting. There is a resolution of the papilla edema in 93% of patients, of the headache in 79%, pulsatile tinnitus resolved in 90% of cases, and overall recurrence of symptoms after stenting was 9.8. But I mean, there is not very long-term results for the recurrence of IIH symptoms, but the complication rate was pretty low. Most recently, there's been a huge series that's been published by the group working in Lariboisière in Paris, and they published quite a huge number. They treated quite a huge number of patients, and with venous pulsatile tinnitus, idiopathic intracranial hypertension, and spontaneous cerebrospinal fluid leaks. You see, under the name of idiopathic intracranial hypertension, there is quite a different kind of population of patients, but everything's go basically to the problems of the venous outflow most of the time. You see how all these patients very often intersect. In their series, it's very interesting because they have a very low rate of complication, okay? And those are the most common complications. Actually, the most dangerous is stent thrombosis. It may happen, and this may be a cause of severe bleeding as well. And growing hematoma requiring blood cell transfusion or surgery is the other most important complication from or clinically relevant complication. Actually, since we used to treat, and we'll see the technical details, we used to puncture directly the internal jugular vein. Sometimes we need to be very careful not to cause hematoma of the neck. This may be really a very clinically important complication as well, because the patient is also under dual antiplatelet therapy. I'm sorry, this is a pretty crowded slide, but you see how the outcome is pretty satisfactory in most of the cases. Pulsatile tinnitus of the headaches. This is basically doubling up the previous publication as well. So it looks that endovascular treatment has a pretty good and satisfactory immediate isn't is effective in sorting out most of the symptoms of this syndrome. And let's now get down to the technical details of the procedure. I used to do it in 2 sessions, as I've said, one diagnostic and the other one therapeutical. But the diagnostic session is very important because it allows you to measure the transtenotic pressure gradient under local anesthetics. The cutoff, the threshold for an indication for treatment is 8 millimeter of mercury. Nowadays, it's accepted also this test to be done under general anesthetic. We only have we accept lower pressure gradient. The gradient needs to be at least 3 or 4 millimeter of mercury. The patient needs to be on dual antiplatelets pre-medication, and they need to go on with dual antiplatelets for at least 3 to 6 months after the procedure. We usually proceed with a groin common femoral artery puncture with a small diagnostic catheter. This is usually only to check the results of the stenting. And the venous puncture is best done at the jugular site. This is because you have to have a very good pushability to go through the sigmoid sinus. And if you go through the femoral vein, sometimes you don't have enough pushability to get beyond the stenosis. This is done under fluoroscopic guidance or ultrasound usually. The gradient measurement, I use a 21 microcatheter, and this is my favorite one. I mean, this is not very complex. You simply use the machine, the anesthetist is used for the invasive procedure. You connect it to the microcatheter. We go for the dominant sinus, obviously, and we have to. The most difficult and most tricky point of the whole procedure is to get beyond the sinuses, the sigmoid sinus and the stenosis with a fairly big long sheath or guiding catheter that is able to sustain the introduction of a stent. This can be done in 2 ways, with a tricoaxial strategy using a long sheath, intermediate catheter, a microcatheter over a 14 wire. I mean, this is very important. Or another way to do it is to use a PTA balloon over a wire placed with a microcatheter. I mean, this is a tricky point because sometimes the stenosis, there are some septation, and there might be small channel, and you want to be sure that before releasing the stent, that you are in the main channel, because you may have problems if you inadvertently catheterize or steer your microcatheter inside the smaller channel. And this is best done with this tricoaxial strategy, or even better with a PTA balloon, inflating it slightly just to see that you are going into the larger channel. Then usually my favorite stent is a wall stent, 7 by 50. It's a pretty long stent, but that's necessary because usually it's shortened up quite evidently. And we need to be pretty cautious about the vein of Labbe. Unfortunately, most of the stenosis are right at the inflow of the Labbe vein. So it's basically impossible not to place the stent across the inflow of the Labbe vein. But we need to be sure before completely deploying the stent or releasing the stent that there is not too much pooling of contrast along the Labbe vein. In that case, obviously, if there is too much pooling, you can try to replace, to resheet and reposition the stent to see if this changes. But if there is persistent pooling of contrast, better to abandon procedure, because the patient is at risk of the major thrombosis of the vein Labbe, and this is usually ends up with a pretty large venous infarction of the temporal lobe and sometimes hemorrhage, so better avoid that. All patients usually have a 3 months MRV. If everything is fine, they stop aspirin and they go on with clopidogrel. And after 1 year, they had a CTA, and if everything is fine, they stop also the clopidogrel. So this is enough from a point of view of the technical procedure. Let's see some case. This is a 64-year-old. It's pretty old, but she had a terrible headache, a pulsatile tinnitus, and a CSF leak. Okay, and that were enough. This was enough indication for treatment. And there is a bilateral stenosis of the transverse sinus, lateral transverse sinus. And there is a dominant sinus on the left side. So this is the side that we need to address. These are the diagnostic phase with the measurement of the gradients. Okay, you see there is a drop from 29 to 24. This was done under general anesthetics. And you see how you don't basically really see the stenosis on the ASA. So you need this imaging to have a proper diagnosis, okay? So once the gradient is measured and there is an indication, we go on with the big catheter and the guide wire, and then there is the progressive releasing of the stent into the sinus. And this is pre and post. You see, there's not a big change. And after 1 year, the fistula is not recurred, and there is no pulsatile tinnitus, and the stent is open and patent. Another case with a hypoplastic right transverse sinus and a stenosis of the right side. This time this is a young female with a 35 BMI, bilateral papilledema, and progressive vision loss, and Diamox resistant. This is obviously the target. The stenosis this case is most likely caused by hypertrophic granulation, arachnoid granulation, and it's this is the usual procedure. You have to pass the stenosis. This is the diagnostic phase with the measurement of the gradients. We proceed to the stent deployment along the transverse sinus, and the result, the stent is patent, and after 1 year the papilledema is gone. The headaches are there, but they are responding to a low dose of Diamox. This is another case in a 40-year-old with headache and synchronous pulsatile tinnitus, Diamox resistant. That's the stenosis. You see, it's quite close to the labbe vein. Okay, the inflow of the labben vein, and this is definitely a tricky point that you need to take into account. That's how you pass the stenosis with the guide wire, the microcatheter, and the intermediate catheter, and then the release and the deployment and release of the stent. In this case, the stent was just released. So let me see. The stent was just released. You see it here, close to the inflow, and I had a precaution not to deploy the stent across the inflow of the labbe vein. This is one of the most technically important, and this is the final result with the resolution of the stenosis. This is another young lady, 35-year-old, with synchronous pulsatile tinnitus and a bilateral stenosis of the transverse sinuses. This is a pretty sharp and severe stenosis of the sinus and was the target. This is a venogram, an injection through the microcatheter, just to confirm the starting and ending point of your of the stenosis. And usual technique, you have to pass the stenosis, then release the stent. So, I mean, and that's the final result. You see that there is still a residual stenosis, but now it's much better, and everything is fine after 1 year. So, from a technical point of view, is not extremely difficult. It is a procedure that can be acquired quite easily with after a few cases. The important thing is to understand what are the tricky point, and it can be, I mean, easily implemented in a hospital as well. Here, actually, the biggest problem is the capacity of the angio room. As I say, idiopathic intracranial hypertension is the tip of the iceberg, because once you start treating this patient, you have quite a lot of referral for pulsatile tinnitus, headaches, CSF leak, and so we need definitely more capacity in terms of angio room spaces, and one single angio room is not enough with the high load of patient that we get from hemorrhagic strokes and ischemic stroke. So, and that's it. Many thanks for your attention, and now it's time for the question time, I think. Yeah, thanks.